Thank you, Dr. Sharif. Alok, I would like to start, first of all, congratulate both of you to such a lovely presentation. And we have some questions from the audiences. So I'll begin with the first one. There is a question which is from one of our audiences, which says that, what about the hypoxic insult in cases needing tracheostomy while waiting for the ENT or pediatric surgeon?
That's a beautiful question. So I will be very honest and frank to say that there are babies who, say, for example, have structural airway problems and they are very difficult to manage and they will have quite severe hypoxic ischemic injury. I think what you've got to be able to do is judge how you've resuscitated that baby. And a good example is we've recently had a baby who's had an airway problem where we've been unable to get a tube down. We've been unable, from our perspective, to actually get an LMA or an IGL down because the baby's mouth was very small. But clearly, from our perspective, that was recognized after the first intubation attempt. So we avoided further attempts at intubation, just mask ventilated that baby in 50% oxygen. We could keep that baby saturating throughout, and we were able to call ENT. Now, that baby saturated and was breathing. It did not have any evidence of problems with either bradycardia or a low heart rate. So we were able to organize a fiber optic intubation for that baby. Now, that is very different from another baby who we managed with tracheal atresia. We couldn't do anything. We could not inflate that baby's chest. And in that situation, while we called ENT, when ENT arrived, it was not appropriate because 30 minutes down the line, giving that baby a tracheostomy after it's had extensive resuscitation, while it's got no heart rate, is not in the baby's best interests. So what I would say is, I would not be gung-ho about this. I would not be giving a surgical airway to each and every baby. I think you have to assess your abilities in the circumstance. And I would say to you that even in our district general hospitals, there are babies who will have severe hypoxic ischemic injury, and they do not have the facilities to be able to do and manage these babies with a surgical airway. It's inevitable that these babies will die. I think the most important thing is you do things with the best of your ability and keeping in mind you try your best. There are some babies that will die despite this, despite your best efforts. So it's considering each individual baby based on its circumstances.
I think that that's a very honest answer, and probably completely agree with you, because we recently faced ourselves, probably 2 years back, we had similar case with tracheal agenesis, and despite everyone attempting, nobody could intubate. And we didn't call the ENT. We decided to let the baby go.
I think that's happened to the majority of the babies I've managed in that situation. Unless they've had a fistula where you can bag the baby, I'll be really honest, we've managed 4. All 4 of them have died.
I think, and the other thing which you mentioned about the kaleidoscope, we have tried kaleidoscopy. We are in process of getting, we have already ordered it, but we had a trial run for almost 6 months, and it is really, really helpful and very useful to equipment to have it.
Especially for the anterior airway, the definition is very good. Gives you a very good view, but more importantly, what I'd say is the hand-eye coordination and learning it is absolutely crucial. For me, the learning curve was about 6 months, and I used to use it in elective settings first, because actually using it in an emergency on an awake baby, I found really challenging. So it does take a little bit of time to get used to it.
Just to add, we've got both the CMAC, so the new blades and CMAC, the CMAC, which has been brought out in the recent past, in the last couple of years, or last 1 year maybe, has newer blades where the camera is at the end of the blade, closer to the end of the blade. So that kind of makes it easier to use. Though they are size 0 blades, they make it easier to use in smaller babies. You also have a company called Accutronic InfenView. They have 00 blades, size 00 blades, which is pretty good to intubate the really preterm babies. We've just bought that as well. The problem with both is that one is like a laptop, so you need to have a space to keep that, and it is not easily portable. The CMAC is also bringing out a portable version, which I tried very recently. They have a screen on top of the blade. So when you're holding the handle like this, you have the screen coming up over here. The problem with that is the screen makes it very heavy. So you kind of don't have control over your hold of the blade. So it is mainly useful in adults, I guess. In our population, it becomes very difficult to use that machine as well.
Just there's a question that one of the audience members has asked on the use of supraglottic airways and delivery of surfactant. And I must say that there's an absolutely beautiful video that's been filmed by Dr. Kaushal, uh, actually providing surfactant using that method. It's so just to say it is perfectly reasonable and a mechanism by which surfactant can be delivered. I know that the guys in Glasgow uh, are actually using it and have successfully been able to use an LMA for administration of surfactant in quite a few babies. What I would say is obviously the recommendation for use of LMAs and iGels is for babies over 2 kilos and over 34 weeks. And that is where there might be limitations in that it's going to be very tricky to use them in smaller babies. You know, in particular, I'd say babies under 1.5 kilograms. So it's definitely doable and usable. And you know, I must congratulate my colleagues, including Dr. Kaushal, an absolutely amazing video on the use of salsa, which is available for people to have a look at.
I think the smaller ones are coming up where the last PAL when we had attended, I saw people using the smaller LMAs as well to deliver for a smaller babies.
So
So I think
the,
it's still coming up. Yeah.
so the Europeans have produced a smaller variety of an LMA, which you can even pass an nasogastric tube down. So just an awareness, an iGel and an LMA in a neonate at the moment, as they currently are manufactured, at least in the UK, do not allow you to pass an nasogastric tube down. So there will always be an element of gastric insufflation, not very severe, that happens when you're providing them. But the Europeans have now produced a size smaller, which you can actually put a size 5 nasogastric tube down, which allows decompression as well. So hopefully, you know, in due course, we'll be able to get hold of that.
And for boogie intubation, so for people who try boogie intubation, it's always advisable that they simulate boogie intubations quite a lot before they actually go into go in and do a boogie intubation, even for an elective tube change, just because the number of case reports with respect to pneumothorax following boogie intubations are quite high. So it's always advisable that you simulate and practice it quite a few times, and then maybe try it on elective tube changes before you kind of, you know, if you face in an emergency scenario to do a boogie intubation, it will not be as easy as it looks.
There's one question, is I want to also ask the same question. They said explain a little bit about sedation, because I observed some of the our colleagues, they insist to make sedation before intubation, but I don't know. What is your opinion about that?
So I'm going to be really honest to say I have lost my equipoise in that I am very pro using a sedative and a paralytic agent where time permits. Uh, I think the use of a short-acting paralytic is what I would recommend. I think there's a risk if you give a long-acting paralytic where the baby stops breathing, which you can't reverse, and you take away the baby's drive and then you can't intubate the baby, then you're in real trouble. So in our setup, what we've developed is we've got pre-made intubation drugs. So pre-made intubation drugs are CVAs, which consist of succinylcholine, fentanyl, and atropine. They come in a sachet and we use a dose banding. It means that we can administer intubation drugs within as quickly as 3 minutes. I would agree that there will be emergency situations which preclude the use of these drugs because it's more important to be securing the airway, and that there is a lot of problem when you have to draw these drugs up. It takes a very long period of time. And I think you have to judge what is safe in your setup. What I would agree is that there's no doubt in my mind that when you intubate any baby who's awake, it's painful, it's uncomfortable. These babies have high blood pressures. We've just done and finished a study on 120 babies where we've used pre-made intubation drugs. And, you know, if you looking at the babies who have emergency intubation with arterial lines, their blood pressures go up, they become tachycardic. You know, there are failed attempts at intubation because of infant vigor and them fighting. It's easier for trainees to intubate if you're using pre-made intubation drugs with sedation paralysis. I think the clinical bottom line for me is if time permits, I would always use them. If time does not permit, it's an emergency. Or if I think that those intubation drugs are going to compromise the baby, maybe a baby with very low blood pressure, I might decide not to use, say, a paralytic agent. I might just use fentanyl for pain. So it's judicious use, but I would say that you need to have a good discussion with your local setup, with your nurses, with your colleagues, and agree a protocol for their use. I think intermittent use makes people more confused about what to do.
Thank you very much. There is another question. What is the smallest age of the resuscitation? For how many weeks you can start? 23 or less?
Okay, so that's a beautiful question. We're running an ethics module in which I've got Sridhar and Monica speaking to us on this, and there's a huge obviously variation in practice based on where you are and which country you're in. What I would say is that in our setup, we would not routinely offer resuscitation under 22 weeks of gestation. We do offer resuscitation above 22 weeks, and I'm going to be very honest to say that we are very circumspect at 22 weeks. So, if I have a 22 plus 5 week girl who I can give steroids to, who's good sized, then my counseling to the parents, if they want resuscitation, is to help and give her a go. But obviously, if she's kind of in a situation where after my attempt at resuscitation, she's not doing well, we would probably move towards comfort care and we'd try to have those discussions with the parents. I think more or less default resuscitation for us is 24 weeks and above. I think 22 to 23 weeks, we're still having extensive discussion with the parents, and parental choice is very important at that gestation. In terms of getting tubes down, I mean, just to give you an idea, I've had a long chat with our Japanese colleagues. They're intubating babies as small as 300 grams. I'm going to be honest, I've not intubated anything under 410 grams. So, but our Japanese colleagues are doing it. How they're doing it, I'm keen to learn from them. So they will be talking to us as part of our module, and we'll be looking at how they manage these babies.
Okay, there's another question. During the time we are trying to intubate the newborn, should we only ventilate with a mask bag?
What I'd say is pre-oxygenation and pre-medication where possible is important. I think what you're trying to do is create enough of a reserve of oxygen to be able to sustain the baby while it's apneic and during your intubation attempt. People talk about term babies needing 3 minutes of pre-oxygenation and 100% oxygen. I think what is really important is it's the judgment of monitoring. So if you've got monitoring on the right hand, using preductal saturations, it's achieving 91 to 95% in preterm babies. It's achieving 95% and above in term babies, and ensuring that you've achieved that before your intubation attempt. Now, that may mean pre-oxygenation for a minute in some babies, but for some babies, it might mean that you have to give IPPV for much longer periods of time. But if a baby's breathing and is saturating, you don't have to give IPPV. You can just give blow-by oxygen by the mask. Let that baby breathe. And that's less traumatic to the baby. What I'd say is if a baby's fighting you and you're trying to give IPPV, just be aware that, especially for preterm babies, some of them will have an exaggerated trigeminal neuralgic reflex and they'll develop glottic obstruction. And that can become more difficult to manage. So if it's not breathing, yes. But if the baby's breathing, simply providing oxygen by mask is more than sufficient.
Another question, can you
Another
use
question.
for Cervanta administration, can you use the laryngeal mask?
So I'm going to be really honest. Should we let Dr. Kaushal answer that? Because she's just recently done it. And, I think her credibility, I'm going to be really honest to say, I've never used an LMA to actually give surfactant. So I'm going to let her answer that question.
Yeah, we had to use it because we had a Beckwith-Whitman syndrome, and when the baby was born, it was such a huge tongue, and we really failed to intubate. And actually, I thought we are more traumatizing the baby rather than helping when we are trying again and again doing it. Hence, we actually ventilated the baby with LMA for 2 days.
Amazing.
And it was quite successful, and we gave surfactant through the LMA. though to be honest, there was a bit of spilling, and we had to use 2 doses, and one was not sufficient. But we could do it, and at least we could get away from invasive intubation and we could just ventilate with LMA just because we could give surfactant. And if anybody is really interested, it's a YouTube. We prepared that, and I thought it would be helpful for people to see like live, because it was a baby and we took permission from the parents to help others to learn from it. So I mean, you can go through that video to learn more. But yeah, I'm saying it wasn't very easy. There was spilling of the surfactant, and so you have to be very careful when you're doing it.
So Callum Ferguson and colleagues in Australia are running a randomized controlled trial with use of the smaller LMAs that Dr. Kaushal has described. They are recruiting babies above 1,250 grams. So, you know, maybe with due course, as technology gets more advanced, we're able to get the smaller LMAs, things will become easier.
Yeah, another question, Alok, is from one of our audiences, that if you are saying that LMAs are better in difficult intubation scenarios, then why don't we use them as routinely instead of bag and mask ventilation?
So I'm going to be really honest to say there are 3 articles being published by O'Shea, a colleague in Glasgow, which is asking exactly the same question. And I can also say that there are hospitals in the UK who are recommending that midwives should keep them as part of their resuscitation for home births, because actually they can't intubate, but putting an LMA and an IGL in is quite an easy and a simple procedure. I think where I stand on that is I think you've got to decide when you're resuscitating the baby whether mask ventilation is effective. If it's ineffective, I'm in no doubt that if you need an airway to establish ventilation because the lungs are a problem, that is to deliver pressure, to deliver surfactant, or you want to deliver oxygenation effectively, then an endotracheal tube would be able to deliver pressures. The problem with using an LMA, you can't deliver pressures above 22 to 24, even with the cuffed LMAs. The other problem with obviously using an LMA is it's a temporizing measure. I mean, you can't ventilate, and I've ventilated a baby on transport with it. But I think if you really want to manage the lungs effectively, bad meconium aspiration, bad RDS, really establishing an established airway with a tube is important. I think for situations where you just need to ventilate the baby, HIE, or say, for example, you have a baby where you can't get a tube in, and you're using this as a temporizing measure, that is, I would say, perfectly acceptable. And I think in due course, I would not be surprised if with more experience and trainees using it, that becomes the norm, is the word I'm going to use. Maybe that's a little bit extreme, but you know, I think we need to be using it more often. A good way to practice it, and this is for my colleagues, my trainees out there, is if you want to learn how to use an LMA, there are some beautiful videos on YouTube. I'll be sending you the links. But for babies who have HIE, who are recovering, who are very poor with their breathing, they're ideal babies where you can, rather than intubate the baby, use an LMA to gain the experience of using an LMA to give them IPPV until such time as you have recovered them. Because a lot of babies have just got mild hypoxia ischemia. They're recovering, their breathing comes back, and you don't actually have to intubate them for long periods. But these are also babies where if you intubate them, they can often become profoundly hypocarbic. So, you know, that's a group of babies where I would say that you can gain experience. And once you get more experienced at using them, if you're struggling with intubation, then yes, I would strongly recommend that you have a supraglottic airway, either an LMA or an IGL as part of your difficult airway pathway.
I think that is also very important to understand. Remember that this is just a temporary measure, and people should not become complacent with the use of LMAs that, okay, I can put an LMA and ventilate.
Yeah.
So call for help, and early call for help is what they should be remembering.
Just one more important point on this. So a lot of adult studies have looked at use of end tidal and capnography, which changes color with the use of LMA and IGLs. Can I say that there's only one randomized trial in neonates which has looked at it, which says that they do change color, but the change in color is not a marker of effective ventilation. So they might be changing color, you might be shifting air, but you might not be effectively moving that baby's chest. And that is absolutely crucial. This baby must improve. The heart rate must improve. You should move the chest. The sat should improve. If that's not working, go back to mask ventilation.
Absolutely.
I want to ask one question for Dr. Jasim, please, if you allow me.
Yeah, please.
For COVID patient, if the mother having COVID positive and she is there now for termination by C-section, I think for the SARS-CoV-2 it cannot be transferred through the placenta. It is only droplet or something. So the baby it will be at high risk if later on mother she will allow breastfeed because it is not transferred by the breastfeed. But for the personnel in the theaters, so everybody will be scared. The anesthetist and even the pediatrician or neonatologist, I mean. So what is your recommendation in this scenario? If
So for a definitely positive COVID mother, we are writing a systematic review on all COVID positive patients as of 2020, and we've only had evidence of 23 cases which have a definitive transmission for which we think might be intrauterine transmission of COVID. So of the 220 cases which have been roughly published based on total number of cases which have had COVID. So in suspected mothers or in definitely positive COVID mothers, previously, maybe a couple of months ago, we were getting the baby outside. So our team will be scrubbed with the full PPE on, with the FFP3 mask and full PPE on, and the baby will be coming out. The midwife will put the baby in a bassinet, move the baby out. The baby will be moved to a separate area for resuscitation, if resuscitation is required. If resuscitation is not required, though the team will still be waiting out. If the resuscitation is not required, they'll give the baby back and continue normal care along with the mother. Now in preterm deliveries or preterm, and we're having quite a few as of like the last month, we're kind of getting quite a few COVID suspected scenarios. What we have decided now is, and the anesthetists also have decided, is before everybody used to stand out, wear full PPE and go in. Now what they do is once they, in a section where they have to do a GA section, once they intubate the mother and they give a 2-minute breakout time. And once that is done, then we all move in. And then we resuscitate the baby at the bedside. And we have decided that we'll continue with delayed clamping as well, with full PPE on. Now, because what they say is that once you have the 2-minute breakout time and the intubation is over, the chances of aerosolization are much lesser.
Yeah, just we because our hospital is designated for COVID mothers who are being delivered. We also do the same, but we from the beginning it's been that we resuscitate them next in theater itself with full PPE, and it's the senior most person or the very experienced specialist tries to go in so that we don't expose many personnels.
Yeah, so we have the senior most registrar and the senior most nurse going in. Generally, you'll have a junior SHO along with the whole team, as well as a junior nurse and another midwife to scribe. Now you'll just have 2 people in full PPE standing resuscitating the baby with 2 people as runners and backups. So we have 2 teams. So in the morning, every day we designate 2 teams. One is team 1, which will be the senior most person and the senior most nurse. Their names will be already designated. So in case there's a positive COVID, they run for the COVID sections. And the team 2 will take the transport incubator along with them, but they will not be in full PPE. They won't wear the full FFP3 mask. They wear the FFP2 mask and the pinnies, and they will wait outside to handle the transport of this baby. So what happens is that once the baby, say a preterm 25-weeker is being delivered, once the baby is stabilized, intubated, and put on the transport incubator, the person, the senior most person who was resuscitating the child will take out all his PPE, and then read on again, because our theaters and delivery suites are 1 floor above. So he will read on again with full PPE, just in case there is a tube displacement in the lift or something, and then bring the baby down.
But it will be not transmitted by secretion. I mean, it is, if we are touching the secretion, the baby or amniotic fluids or something, it will not be transmitted.
They are wearing full PPE anyway. So the chances of transmission are low, but they are wearing the full PPE. One, two is that we have said any COVID suspected or COVID positive cases, they wear the full PPE. So no taking chances.
So
Yeah.
Jasim, you are doing delayed cord clamping. That means.
Now we have restarted delay. So we had defer in COVID suspected and COVID positive mothers. We had deferred it for the initial few months or till a few months ago. But then now that we have realized things have changed, protocols have changed, we have restarted doing it.
And Rajesh, because I think what Hafiz had, he had one of his COVID positive mothers data he had released, and what that time I don't think so they were doing delayed cord clamping. So are you guys started doing it, or it's
No,
not been
we haven't started yet. Again,
okay.
COVID.
Okay.
So for term babies, it was happening anyways. So if they're inside,
Even if the COVID.
yeah, the midwives were doing what they would normally do, because because our whole research team is outside the area. So the midwives what they would normally do in full PPE.
Yeah, if there is no high risk patient, just a normal delivery with COVID mother,
yeah,
then they do the normal things as Jasim said.
Yeah. And in preterm babies, we kind of deferred it till a couple of months ago, and now we have decided that we'll go back full and like not to actually say that COVID baby patients should have a different care compared to non-COVID patients. Also the number of suspected COVIDs also have kind of increased comparatively compared to the initial period as well.
Yeah.
So any patient with fever is suspected COVID till we have the reports back. But nowadays we have rapid COVID test swabs, which they can report back in half an hour's time. So all and we have 4-hour rapid testing as well. So all COVID patients, suspected COVID patients, and in-house patients are tested. We also had a baby which had the meconium aspiration syndrome with a COVID positive, and this was in the early time. So the lungs, we are still not sure. Actually, we are writing that case up. We are still not very sure whether it was COVID pneumonitis or whether it was meconium aspiration, which caused all the problems of the baby.
So I have a question as well. Very nice talks from both of you, very practically useful. And we have all faced situations. Now with the Insure and the LISA techniques coming up, one of the applications we had the CMAC and the new model which you described we had as well with the zero blade. I totally agree with you. It's a little difficult to handle it. And as Alok rightly pointed out, the orientation is not easy. So you do need practice a few times on the dummy. And when you're live, you have to really focus on where you're going. And the old instinct of looking in does happen. So you're actually missing looking through the video. We tried using it with the feeding tube for Lisa. And if you put it through the groove of the CMAC, it goes right to the airway. So if you're able to keep it in position, we can use it. And we didn't use it on many babies, but this practical application is one thing if you're considering investing, especially Rajesh was mentioning. So if you're considering investing, I definitely encourage that. And I don't know, Alok, if you saw the results of the poll. I think 59% had said 2 attempts. So what's your thought?
So what I would say is the question is a trick question. So the question as it's asked talks about intubation in attempts. I want to take you away from that concept. I want my trainees to think about why they failed, what they're going to do next, and what they can get in between. It's called the Q3 approach. So the Q3 approach is one that's been recently published by the British Association of Perinatal Medicine. What they've emphasized is that rather than thinking about number of attempts, once you failed your first attempt at intubation, you should think about the reasons for failure of that attempt, anything that you can do to correct that, and what you're going to do differently. But a rough guesstimate, and our literature would say that an experienced provider, you should not have more than 2 attempts of intubation by the same person. The risk is fixation. And the other risk is obviously for people as experienced as ourselves, we sometimes bring our egos into this. And that's not good for the baby. In an honest environment, I'm going to be really honest to say, I've had difficulty intubating a 25-weeker 18 months back. And I've got a trainee who's very, very experienced, And I had 3 attempts, and I said, fine, let's give him the chance, and he intubated in the first attempt. So sometimes in situations like that, you have to default to letting a fresh pair of eyes have a look. But rather than thinking about the number of attempts, what I would say is, you failed your attempt. Why have you failed? What are you going to change about your next attempt? And really, do you need to intubate babies is the other question. Is there something else you can use in the interim? And for babies with Pierre Robin in particular, I'm going to be really honest to say, I've not had to intubate a baby with Pierre Robin for the last 2 years now, because we've used humidified high flow in the delivery suite. We can get them to adapt. We can actually use nasopharyngeal tubes where they struggle. So actually, the real question that you have to ask in those babies is, do I need to tube?
We have slightly moved to a new kind of way where we say that the most experienced person in extreme preterm babies, the most experienced person goes for the intubation. You don't give it to the junior trainee to learn in extreme preterm baby. So this is just to optimize intubation. We've seen there have been instances when junior trainees have tried, not got it, and the second attempt the senior trainee gets it in. But we thought that to optimize intubation, the best way forward would be to give the most senior person there in these babies the best chance to get the tube in. So we have, in our unit, we have advanced neonatal nurse practitioners as well who have years of experience, and they intubate almost anything as well. So sometimes they go ahead and do the tubing.
I don't know if you attended the lecture by Professor Jonathan Stein on 22-23 weekers in Iowa. So he said they have a separate team just for these babies.
Yeah.
Once they go below 26 weeks, only the most experienced people handle them from day one till they're taken to be stable. So it's a very sensible approach.
Yeah.
And Dr. Sharif's question about pre-medication, it's a very important one. And having worked in both setups, Alok, when I was in UK, we were very used to this. And actually, Chris Lilly in Glasgow was the first one who thought of this pack of pre-medication stuff, which is very handy and everyone is using it. But after moving here, when I've seen people who are stable in jobs, we don't have trainees anymore. We have only the senior people intubating. One of the negatives of pre-medication was obviously the bradycardia episodes we used to get. The fentanyl-related chest wall rigidity, difficulty bagging. The period you bag the baby is much more when you're using pre-medication. And when you're having a slick intubator, you oxygenate if needed, as you said, to 90 to 95%. You don't need to pre-oxygenate with 100%, knowing the toxicity of oxygen.
Yep.
And then you go in without pre-medication fairly quickly. Mostly 1 or 2 attempts at the most. There is not much trauma as we would visualize. So it's experience of the intubator that matters. And in UK, because the trainees are having a look, and we also get used to that concept. So even we are used to pre-medicating. And when we do it ourselves without pre-medicating, it's actually easier because the laryngospasm that you said, the medication also has a contributing effect to that. So in our unit now, because we have a stable team, we don't have trainees, everyone is only improving with intubation skills, which is already good. So we don't use pre-medication except for the most difficult cases. And just one point, I think, about the, what was I about to say? Sorry, you carry on. I forgot that.
I think, I don't know, if, Dr. Alok, because we don't, as we trained, we never did pre-medication. And when I had gone for 3 months to UK and I saw that pre-medication thing, sometimes being followed and sometimes not followed even there. What Sridhar said, because we feel that we have done it very easily, but I don't know what happens physiologically, even in that once attempt to the baby, like as he said, if the baby becomes tachycardic and the blood pressure shoots up if we don't do it, pre-medicate them. So I'm not sure. I don't do it myself, but I'm not sure whether we are right, even if I have done it quickly, not pre-medicating those babies.
But the other point we have to consider is the damage to the lungs by bagging for a while, or the bradycardia episodes. If you need chest compression, for example, even briefly, it's not going to be beneficial for the baby. So it's a balance
That's what I'm saying. Like, what would be the?
I think what we have done is we have divided into 2. When it's an elective intubation, we always use pre-meds. If it's a semi-emergency, again, we try to get medications before we intubate. But as you know, in UAE, unfortunately, we cannot get MRN numbers before the baby is born.
Yeah.
Cannot get medications before the baby has MRN. So if it's a delivery room intubation, it's almost 100% without pre-meds.
Yep.
Because we cannot get the medications.
No, you can have emergency medication, Rajesh.
Yeah, but not
Okay.
in our setup. We can only get it if the MRN is there. If the baby does not have medic number, then we cannot get it. So in delivery room, generally we get it, but we generally intubate them without pre-meds in delivery room. But it's an emergency situation. And again, as you were mentioning, if it's needing a cardiac compression, I don't think anybody will wait for pre-medication.
No, absolutely.
Yeah.
I think very fair points that, all my senior colleagues have kind of alluded to. And I think I do agree with one aspect of what Sridhar and Rajesh sir are saying, is that what we want to try and do is not take the baby's drive away for a very long time, because the risk in that situation is we then consign them to the need for ventilation. And, with Lisa coming in, as well as with the ability to be able to give surfactant by that method, actually the need to ventilate these babies is less and less. I think we had a huge debate on whether we should be using sedation with Lisa recently on Twitter. And, again, there are two schools of thought, because we don't use sedation with Lisa at all. I just use atropine. And the reason and my thinking there is I don't want to take the baby's drive away at all, especially the more preterm they are. But there's some of my colleagues who believe that we should. And I think what we really need is a good randomized control trial, which actually looks at our ability to be able to measure pain, to be able to demonstrate the efficacy of these drugs with good follow-up of long-term neurological outcomes. And I think that's lacking.
So I remembered what I was about to say. I know you run the advanced or difficult airway course. So I mean, one of the useful tips that the NRP textbook gives you is to hold the tube horizontally, so you're not hiding by the tube going in.
Yep.
So that is something that the trainee should remember. And the neck position that people keep, sometimes if you overextend it, the larynx goes very high. Yep. And the angle is not achievable. So in addition to the cricoid pressure, I mean, you have to keep the neck in as straight line as possible, a little shoulder roll, but not too high. And don't overextend, because we tend to overextend. The overextending is not good for the IVH risk as well. So do you have any tips like this which you would like to tell, especially for the extreme preterm intubations? And have you ever tried finger intubation?
Never ever done or tried finger intubation. So any kind of blind approach to trying to intubate any baby is fraught with risk. There's also a risk of trauma to the airway. So I've never done it. I've read about it, but never done it. I think what I would say is I completely agree with you on overextension. We have some lovely videos, and I will supply Tawfiq with the links to them, which actually show with a video laryngoscope what happens when you overextend and how you compromise your view. And what is really helpful is if you've got another person watching you and you're failing due to that reason, they can actually tell you that you're overextending, because sometimes you're so fixated and so close to the baby, you don't realize that you're overextending with your actual process. So that is very important. The other thing that I would say with extremely preterm babies is with the video laryngoscope in particular, some tips. So preloading, as you described, very useful. So preloading means that you can actually take your endotracheal tube and keep it right at the tip of the video laryngoscope, but you'd be using the screen to intubate. And the other thing that I found quite useful is having a nasogastric tube down. It delineates where the esophagus is. So especially for trainees, when we're trying to train them to differentiate the glottis from the esophagus, the ability to be able to visualize the nasogastric tube going down the esophagus then is a good marker that that's the esophagus, and actually the glottis should be anterior to that, especially when they're using the pullback approach. So, I completely agree with you. A shoulder roll, again, very, very useful in circumstances like that. And the other thing I would say is obviously making sure that you're using the right blade size for the right baby. So, for extremely small preterm babies, I would default to using a 00 blade under 700 grams routinely, because I just find you have more space to be able to put the tube in. On the other hand, I would say that, for bigger term babies, above 3 kilos, you really want to use a size 1 rather than a 0 size laryngoscope. So you're right. All of those aspects are very important.
We have actually moved on to
question for Jasim.
Yeah.
Criteria for diagnosis of positive Like really, what is your criteria when you say newborn is positive, COVID positive? And are you using aerosol box for COVID deliveries?
No, we're not using aerosol box for COVID deliveries because the babies were coming out till recently. So we're not using the aerosol box. And if you're actually trying to intubate using the aerosol box or a screen in front, it kind of makes it even more difficult. So we have the shield on. So one of the interesting things we learned from simulation when we were simulating during the the start of the COVID pandemic was that I remember one of my trainees telling me he had this shield on. He's telling me that I can't see anything, I can't see anything, I can't intubate. So we took out the shield, and the shield actually had a film on it, which he had forgotten to take out. So that is why he couldn't see anything. So these were things which we learned with the simulation during the COVID pandemic. Now, our criteria to say that the baby there is the intrauterine transfer is if we feel that if the rapid test of the mother is positive, and the baby also we do a rapid test and it becomes positive, then we would think, and if the baby is having symptoms as well, then we would definitely say that there is a possibility of intrauterine transfer. So if you have rapid COVID positive baby and rapid screen positive for mom as well. We are also following up all the babies of these positive mothers as well in clinic, just to see that they are all fine over here. And the few of them I have seen are all okay. So, like I said, there are only 23 cases reported in English publications around the world who might be a possible intrauterine transmission of COVID. And again, all the papers, they don't have definitive criteria. They have used vague criteria from what we are writing up now.
You had some comment about the previous question.
I think I lost my flow of thought. It wasn't about the video laryngoscope, isn't it? So the tips, you asked for tips. So one of the tips I have is if you're going for less than 24-week intubation, a small baby, 350 grammer or 400 grammer, and you need to use a size 2 ET tube. Most of the times what we try to put introducer into the size 2 to intubate these babies. Now the normal introducer we have over here, I'm sure that will be the same make in almost every resuscitation unit. They won't go through the size 2 tube. They're too tight. They won't go through the size 2 tube. So it has a film on top of it. You'll have to strip that film off so that the introducer goes through the size 2 tube. So that's something which people have to bear in mind when trying to resuscitate these babies. Also, the smaller babies, we have kind of said that we'll be using a triple lumen UVC. So the standard triple, instead of the double lumen UVC, we are looking at using triple lumen UVCs for the smaller babies for resuscitation. We've had 2 22-weekers which have come through after the BAPM guidelines have changed, where parents want full resuscitation. And we are learning with every 22-weeker.
I think because of the constraint of time, we'll have to stop our session here. Though it's such an interesting kind of a presentation, and you guys really helped me out, like making it so practical. And actually, we got the answers of the nitty-gritty of small things which we face in every day when we are managing these kind of babies. And so Dr. Alok, Dr. Jasim, Dr. Sharif, Rajesh, Sridhar, thanks everyone. And Tawfiq, thank you very much for making this.
Thank you, Tawfiq.
Yeah.
Thank you,
So
Tawfiq.
very IT, all nitty-gritties were well managed.